Okay, can you see my slides good?
Yes.
Okay, good afternoon, everybody, or good evening, depending on what part of the country you're at. We have a great Good Hormone Health webinar tonight entitled Dueling Academic-Based Endocrinologists Discussing State-of-the-Art Hypothyroidism, Diagnosis and Treatment, Commonalities and Differences. I'm delighted to be joined by Brittany Henderson, MD at ECNU. And Brittany, say hello and introduce yourself, please.
Hi, everyone. I am a clinical thyroid endocrinologist. I previously ran some thyroid programs at major academic centers, including Wake Forest Baptist and Duke University. And now I own my own practice in Charleston, South Carolina, where we focus on just the thyroid, and I'm board certified in endocrinology.
Great, welcome aboard. Thank you. So our topic today is each expert will discuss the following topics. How is mild hypothyroidism diagnosed? Why are full thyroid panels and not just TSH needed? What is the role of reverse T3? How to optimally use all types of thyroid hormone, including natural desiccated thyroid extract? Why both conventional and alternative providers have it wrong? And we will briefly discuss the proposed ban on desiccated thyroid by the FDA. The thyroid sits in the middle of the neck. There has two lobes, the right and left lobe, and there's the thyroid cartilage above it, the cricoid cartilage beneath it. It's right above the trachea. The thyroid hormone makes two hormones, or three hormones, T4, T3, which is the active hormone, triiodylthyronine, and so T4 is a precursor hormone to T3. It also makes reverse T3, which both Dr. Henderson and I will talk about, and it also can make T2. The main one we're going to be talking about is T4 and T3 and reverse T3. It's regulated by TSH so that when your thyroid hormones go down, your TSH rises to compensate. So how do you diagnose hypothyroidism? First of all, hypothyroid symptoms, that helps, but it's non-specific. Many people have things like fatigue and feeling colds and joint pains and brittle nails and hair loss. Elevated TSH, yes, probably the most important thing, but what is the cutoff? A rise in TSH. It's important to look at trends. If somebody's TSH a couple years ago was 1, and then 2, then 3, then 5, that's a sign that they're developing hypothyroidism. The positive TPO antibody is the most important test. Diagnose hypothyroidism. First of all, Sophie, can you mute everybody?
Yeah, sorry about that.
Okay. Um, the thyroglobulin antibody, and I'll show a reference for that, is not particularly helpful for Hashimoto's. Um, you can look at the free T4 or total T4 and free or total T3. They usually are normal in primary hypothyroidism, at least untreated primary hypothyroidism. However, they can occur in central hypothyroidism. Many of my patients have pituitary problems as they had prior surgeries and things like that. So for me, it's a very important test. For Brittany, that sees mostly primary hypothyroidism, it might be a little less important. Once someone starts thyroid hormone replacement, it suppresses their own thyroid production. So most of the patients who start thyroid medicine stay on it for life. So it's a big decision. I think if you're telling somebody to go on this medicine for the rest of their life, there has to be pretty good reasons for it. It's often worthwhile seeing a specialist, such as Dr. Henderson or myself. And if you're unsure, repeat the test and look for other causes of some of the symptoms that a person may have. And I always comment that I spend half of my time taking people but starting people on thyroid medicine that should be on it, and the other half of my time taking people off thyroid medicine that shouldn't be on it. And again, the reason why it's important not to treat somebody unless they're truly hypothyroid is it suppresses their own gland and can actually make things worse. Go ahead, Dr. Henderson.
Okay. So here's where we agree. So I think for mild hypothyroidism that it is underdiagnosed in conventional medicine. So when you look at conventional medicine endocrinologists who have been trained in the thyroid, many of their practice guidelines say that you shouldn't treat an elevated TSH unless it's up over 10, maybe sometimes up over 4 in some patient populations. Especially if patients have a normal free T4 or free T3. Um, I tend to disagree with that. I think that there is a place to treat patients when their TSH is above the reference range and even above what we consider optimal range, depending on what the rest of the panel looks like. That being said, um, TSH elevation does not automatically mean that the patient is hypothyroid, and it doesn't automatically mean that a patient should be put on thyroid medicine. So there are a lot of people who are placed on thyroid medicine that should not be. TSH goes up when there's any type of inflammation in the body. It can go up when there are interfering medications, including inhaled steroids or beta blockers. It can go up when there's iron deficiency. There are so many reasons to have that elevation in TSH. And sometimes that's an appropriate compensatory mechanism. So I have patients in my practice who have a TSH over 4 or even over 10, and we don't put them on medicine because they feel good and their whole axis looks good. So there's no reason to do that unless they develop metabolic consequences like hyperlipidemia or hypertension. I will say that there is a problem with a delay in proper diagnosis. So, according to some of these references that I listed below, up to about 8% of the US population has undiagnosed hypothyroidism, and that's true hypothyroidism that warrants treatment. I will also make the comment that subclinical hypothyroidism is a heterogeneous disease state. So there are people who actually have true hypothyroidism with a TSH over 4 or over 10. But number one, the condition is not subclinical if there are actual clinical symptoms. So there are many patients who present with a TSH in that range with fatigue and with hair loss and with skin changes and nail changes and constipation and all of the classic hypothyroid symptoms. And if there are clinical symptoms, it warrants consideration for therapy. And then I also want to make the second point that really subclinical hypothyroidism is a confusing name. I really think that it should be called something like HPT upregulation, hypothalamic pituitary thyroid upregulation, with or without compensation, depending on if the thyroid can respond appropriately to the higher TSH level. But subclinical hypothyroidism to me is very confusing. And then lastly, the right patient needs to be treated.
I agree that that's an incorrect terminology.
So then I will say that mild hypothyroidism is oftentimes overdiagnosed in functional medicine or in integrative medicine, and these are probably half of the patients that you're taking off thyroid medication.
Correct.
Um, because, a lot of these people see functional medicines, they're fatigued, they have these like symptoms that could or could not be thyroid related. And I will say, just an isolated low free T3 does not automatically mean the patient is mildly hypothyroid. Many times that means that there's a problem with peripheral conversion, so typically inflammation or other issues. Sometimes I will put patients on a little T3 when they're really symptomatic, just as a Band-Aid, but that does not mean that they're going to be on it lifelong, and we do not suppress TSH, so me putting somebody on it for a short time does not mean that they don't come off of it. Patients don't come off thyroid medicine because they're put on medicine by endocrinologists that just never consider taking it away. Um, and then also that an isolated high reverse T3 or high reverse T3 to free T3 ratio does not automatically need treatment. Usually I look at the underlying cause for why that's happening and try to fix that. Um, Obviously, overdosing patients on thyroid medicine is never a good thing. And I will make the comment as well that I think as endocrinologists, we have lost the thyroid population because a lot of these patients will seek care elsewhere because there are a lot of uneducated endocrinologists that don't treat patients appropriately and think that they know better than everybody. So, they go see functional medicine, they go see chiropractors, and those patients oftentimes get overdosed on thyroid medicine because they are being treated by practitioners that haven't been properly trained in dosing. Um, I will also comment that there are many causes for altered peripheral metabolism, and that can look like true hypothyroidism or it can look like an isolated free T3 level. But figuring out why that's happening and fixing that part is more important than just putting people on unnecessary medication. And then lastly, that persistent altered peripheral metabolism, meaning that there's a low free T3 or a high reverse T3. can lead to metabolic consequences. So this is why people develop weight gain. This is why people develop fatty liver disease. This is why people develop hyperlipidemia, hypertension. And it's not maybe due to the thyroid not being active, it is due to altered peripheral metabolism because of multiple other inflammatory or metabolic issues that are going on that need to be addressed.
And I would also comment that the free T3 assay has a fair amount of variability. I think we underestimate variability of labs. We trust them as on the Bible, but you repeat the lab and sometimes they're a little bit different. I think the free T3 has a fair amount of that, has a pretty high coefficient of variability. So that's can be frequently isolated low one time, repeat, and the next time it's okay. You see that a lot?
Not really. I mean, I guess, by maybe 5 or 10%, but I'm talking about significant changes
Mm,
in free
yeah.
T3.
Okay. Go ahead.
Oh, sorry. Okay, so why a full thyroid panel? So, I'll talk about this in a couple subsequent slides, but you already saw this diagram. So TSH, thyroid stimulating hormone, is actually a pituitary hormone. It's not a thyroid hormone. And so looking at TSH only really doesn't look at, number one, how the thyroid is responding to the TSH signal. TSH doesn't always respond appropriately, especially in an aging pituitary gland. So sometimes you can have an inappropriately normal TSH with lower free T4, free T3 levels or lower total levels. Also, it doesn't take into account peripheral metabolism. So 80% of what the thyroid produces is T4, inactive thyroid hormone, 20% is T3. And then you're relying on muscle tissue, kidney, liver, the peripheral tissues to take that T4 and activate it to T3, active thyroid hormone, through these deiodinase enzymes. So deiodinase 1 and 2 are the primary activating enzymes, and deiodinase 3 is the primary inactivating enzyme. So that one takes T4 and makes reverse T3, which we're going to talk about here in a second. But that whole process is very individualistic. It also depends on multiple factors, including whole body systemic inflammation, interfering medications, um, fat to muscle ratio. Unfortunately, we live in the United States of America, and a lot of our people around us have a higher fat ratio compared to muscle ratio. And so, back in like the 1950s when Synthroid came out and everybody was on T4 only, the fat mass and the fat percentage in Americans was a lot lower, so they could take that medicine and convert it better to T3. Now we don't do that very well. So this is super important to understand the person and understand how the person is taking up the medication and how they're using it, how they're metabolizing it in the bloodstream, because it directly correlates with patient symptoms. When you're using TSH only, and that's what's advocated for in our guidelines by the American Thyroid Association and ACE and a lot of the endocrine guidelines. You're making several assumptions. So these are the three assumptions, and I have the TSH curve from the NHANES data there. So a normal curve, when you're looking at a data for what's normal, and you're looking at a population of normal patients, that curve should be a bell curve. It should be normal, normally distributed. The TSH curve, at least from NHANES 3, was skewed to the right there. It has this big tail, and the tail makes you kind of question, like, should some of those patients have actually been included in this data set? And I have that down here. But assumption number one is that the laboratory assay and the reference range are true normal. So NHANES was this big study. It was performed from 1988 to 1994 to look at what is a normal TSH, and they looked at this big patient population of over 17,000 patients. They did exclude patients based on specific criteria to try to effectively get rid of patients with known hypothyroidism or Hashimoto's disease. And the resulting reference range was this 0.45 to 4.12, which is pretty similar to what you see on your normal reference ranges when you look at your labs. It's usually like 0.45 to 5 or something like that. And this is the curve. So there's obviously something wrong with it because it has this long tail. Subsequent guidelines from the National Academy of Clinical Biochemistry, which is now the American Association for Clinical Chemistry, looked at this and looked at some other data and proposed a narrowing for the upper limit of TSH normal to 2.5. And this was based on the observation that in rigorously screened euthyroid volunteers, and I think they looked at NHANES later on and found that about 15% of patients in that study did have underlying Hashimoto's or hypothyroidism that were not known. And so when you remove those patients, you get rid of the tail, and your normal TSH values then go between about zero point 0.4 to 2.5, which is typically what we use when we talk about optimal TSH dosing. Assumption 2 is that the HPT axis is intact and in charge. So that means that the pituitary is actually signaling to the thyroid, and it is in charge of what's going on. The obvious example of when it's not in charge is hypopituitarism, like you said, Dr. Friedman, when you have patients who have had pituitary surgery and the pituitary no longer signals to the thyroid. But there are so many more common scenarios for this: sick euthyroid syndrome, chronic disease like fatty liver, chronic kidney disease, diabetes, inflammation, pituitary aging, multiple medications that interfere with this signaling. There's many, many of them. Amphetamines, a lot of people are on those. Metformin, spironolactone, glucocorticoids, including inhaled glucocorticoids for asthma, NSAIDs, Lasix, so many common medications that interfere with TSH signaling. And we know that a lot of these thyroid hormone metabolites, including T1 and T0, actually suppress TSH. So these are metabolites that we can't even measure. So you have to look at the full panel. Also, I will disagree with one of the points already that thyroglobulin antibodies are not helpful. Clinically, they are helpful. We see that they are destructive in many times on ultrasound examination, and they are many times stimulating. So you actually can have patients have Hashimoto's symptoms even with negative TSI or TRAbs. And these antibodies basically attacking thyroid tissue can cause TSH to be anything. It can be normal, it can be low, it can be high, it can be whatever. Um, it's an average hormone level. So these antibodies being in charge instead of the pituitary and the hypothalamus being in charge really can artificially normalize TSH. And then the assumption number 3 is that peripheral metabolism is unaltered, and that is the biggest issue. I mean, you can have a normal TSH and a normal free T4 after reflexing and have a low free T3 or a suboptimal free T3. And that is because of prescription medicines, inflammation, metabolic composition, iron deficiency, changes in carrier proteins, and in menopause, and there are multiple studies that show that that as the carrier proteins decrease in menopause and in women, that they can't convert T4 well anymore. So again, this is why we say full thyroid panel when we talk to thyroid patients, and we ask them to please ask your doctor for this. Then you have to find a doctor that knows how to interpret it and how to dose based on it.
Okay, so why a full thyroid panel? TPO antibody, I feel, is the most important test. It's to be measured in all patients. Hashimoto's is the most common cause of hypothyroidism. If somebody has a negative TPO antibody, I question really whether they have Hashimoto's and whether they've got hypothyroidism. The Hollowell paper that Dr. Henderson quoted did look at antibody levels, and only the TPO antibody was correlated with hypothyroidism. There might be other studies that found thyroglobulin antibodies, but it seems to be the gold standard study. And some of this was done at USC in Los Angeles. Um, TSH is different TSHs versus starting thyroid medicine. So when you treat somebody, you can basically make the TSH whatever you want. And I usually aim for less than 2.5 as a treatment. But in terms of starting thyroid medicines, again, you're causing somebody to go on medicines the rest of your life. And I'm usually a little bit more reluctant to do that. Um, so if somebody has a negative TPO antibody, I would probably start them if their TSH was greater than 5, maybe even not start them TSH, maybe repeat it again. But if they do have a positive TPO antibody, they have their gland being attacked. And if it's being attacked somewhat by the antibodies, eventually a good portion of them will develop hypothyroidism. So I think it's fruitful to start them on thyroid medicine um, sooner rather than later if they have a positive antibody. And the antibody is quantitative, so if they have a high level, I might be more willing to start them than if they have just a slightly elevated level. 2.5 if they have antibodies, 5 or so if they don't have the antibodies. I usually measure free T4 and free T3 to look for central hypothyroidism. I usually don't measure thyroglobulin, total T3 or total T4. And I think doing a survey is helpful. My colleague at Bethesda Medical Center, Dr. Hong, does a thyroid symptom questionnaire. I incorporated that into my new patients. There's many thyroid questionnaires out there, but doing one is probably a reasonable idea. And if somebody has a higher score, they're more likely to benefit from thyroid medicine. Okay, reverse T3. Most of circulating T3 is derived from the 5' deiodination of circulating T4 in the peripheral tissue by type 1 deiodinase. And you can see over in here that it's causing, let me see my screen. So it's causing to go from T4 to T3 over here. However, you can also get deiodination of the outer ring, um, or producing T3, or you can get it in the inner ring to give reverse T3. So reverse T3 is shown over on the right side here. It's by the iodinase 3 primarily. And the 2 can do it sometimes, but this gives you reverse T3 levels. Type 2 deiodinase in the pituitary also converts T4 to T3 and is well regulated. Reverse T3 is the biologically inactive form of T3, and I think there's not great data on this, but there's some data that it may block T3 from binding to the thyroid hormone receptor. Many years ago, endocrinologists realized that in severe illnesses, the type 3 deiodinase increase, and reverse T3 is often high, T3 is often low. Endocrinologists term this sickly thyroid syndrome. This was very common when I was doing my fellowship maybe 25 years ago or so. I think it's a little less studied now. And they notice this is common in many types of chronic illness, especially in patients hospitalized in the intensive care units. And it was usually recommended these patients not be treated with thyroid hormone. And in most cases, the elevated reverse T3 resolve when the patient's health returned. So what are some factors that cause T4 to go to T3 versus reverse T3? On the right side is things that cause it to go the right way to T3. The left side is things that can cause um, improper conversion. So things that cause um, um, natural, normal production of thyroid hormones include iron, iodine in small amounts, tyrosine, zinc, selenium, vitamin E, B12, B3, B6, and C and D. And things that can inhibit the proper production of thyroid hormone include stress, infection, trauma, radiation, fluoride, which is an antagonist to iodine, toxins such as pesticides, mercury, cadmium, and lead, and celiac disease. Factors that increase the conversion from T4 to reverse T3 include stress, trauma, low-calorie diet, inflammation, toxins, infections, liver disease, and kidney disease, and certain medications. Factors that increase the conversion are selenium and zinc, so it's important to make sure people are often can often be taking those. We don't in the United States have too much zinc or selenium deficiencies, but those are, especially selenium, something you can give people to help with the T4 to T3 conversion. And factors that improve cellular sensitivity to thyroid hormones include vitamin A, exercise, and zinc. My colleague, mostly Julie and Wilson, compiled data from our lab, from my practice actually, when Dr. Hong helped us out a little bit. Martin Lee was our statistician, and we published in PLS1, which is a fairly prestigious journal, peer reviewed by the Public Library of Science. It's posted on Good Hormone Health, and there's the reference to it. And we looked at a good set of patients, 956 patients, that had different treatments for hypothyroidism and measured reverse T3 at either LabCorp or Quest in them, and found that a good portion of them have a high reverse T3. We looked at 976 patients who came to Good Hormone Health with potential thyroid problems, and pretty much they all had symptoms of hypothyroidism. They all really had fatigue. That's why people come to see me. Many of them were already treated with different thyroid preparations. And we found that the number of patients with a reverse T3 above the range varies significantly with the type of thyroid hormone replacement. Overall, 11% of the patients had an elevated reverse T3. The highest rate of reverse T3 was in patients taking T4 alone. So the T4 can lead to high reverse T3. 9%, which is a little less than the average, a patient not taking thyroid hormone replacement had elevated values. So this is more of a problem in patients on treatment taking, especially T4. In contrast, only 4% of the patients taking desiccated thyroid hormone had above normal reverse T3 average. 12% of those taking a T3, T4 combination, and 17% of patients taking desiccated thyroid T4 combinations. Patients on all types of levothyroxine had higher reverse T3 than those not on levothyroxine treatment, and a higher percentage of reverse T3 above the cutoff of 24.1. This was highly significant. So again, treatment with levothyroxine T4 can lead to high reverse T3. Treatment with the T4 T3 combination or desiccated thyroid gives you less of that. And linear regression analysis showed that the reverse T3 correlated with the free T4 levels and more weakly with the free T3 levels, and inversely with the log TSH. So those with the high T4 are more likely to have a high reverse T3. Our results show that patients on levothyroxine alone, often considered the gold standard for treating hypothyroidism, had the highest level of reverse T3, the biologically inactive hormone that accumulates when the body fails to convert T4 to T3. In contrast, patients using T3 treatments, such as desiccated thyroid extract, had significantly lower reverse T3 levels, suggesting that standard therapies may not be optimal for all patients. And as my university continues to champion research that serves underserved populations, and just addresses longstanding gaps in health equity, the study underscores the value of re-examining medical norms in light of new data and patient experiences. This is from our press release. So the high prevalence of patients with thyroid preferences other than the LT4 reflects the heterogeneity of providers, as well as the dissatisfaction with conventional treatment among this group of patients. We found that the type of patients with an elevated reverse T3 varied depending on the thyroid medicine they were taking. It was higher in patients taking T4, lower in patients taking T3 or desiccated thyroid preparations. And groups that took the desiccated thyroid or the LT4 plus LT3 had a larger percentage than groups that took the same preparation with T4. So T4 again made things worse. And at least in our study, T4 raised reverse T3 levels, and levothyroxine could lower them, although these effects need to be verified in larger prospective studies. So overall, our conclusions of our paper were measuring reverse T3 may be helpful, especially those on thyroid treatment that contains T4. Reverse T3 is less likely to be helpful in those not on thyroid medicine because most of those were normal patients that have an elevated reverse T3 on thyroid treatment with LT4 alone or LT4 plus LT plus desiccated thyroid. They benefit from decreasing the amount of LT4 given and increasing the amount of T3 given or the desiccated thyroid given. Okay, Dr. Henderson, do you want to comment on reverse T3 in your practice?
That was so good. Thank you so much for
Thank you.
contributing to the literature in
Thank
that.
you.
Like, I mean, that study needed to be done. So thank you
Yeah.
so much for doing that. Do you have stored serum from all of those patients? Is that how you were able to do that?
No, so when we measured it when they came to the clinic, we sent them to LabCorp and Quest, and then I got IRB approval to retrospectively examine my data, and we looked at my charts, and Julian looked at my charts, and we pulled it out of my data.
Got it. Got it.
Yeah.
Got it. Okay.
Okay.
Well, I will
And
I
I'm still measuring it, and I think hopefully we can collaborate, and you can start measuring your patients and see if you see sort of the same pattern that I'm seeing.
I measure it on all my patients. So I am
Hmm.
definitely seeing the same pattern that you are seeing. Yes.
Hmm.
So I will say that the study is definitely what we see in the real world as a clinical thyroidologist doing this all the time. Yes, people coming in on T4 only, especially people that have a lot of inflammation. Think patients with osteoarthritis or rheumatoid arthritis or postmenopausal women who don't have estrogen around anymore and who have low levels of something called TBG, which is the binding protein for T4. They don't convert T4 to T3 well anymore. So we see this. And I will go so far as to say that the different formulations of levothyroxine, because there are different manufacturers, there's also the FDA approved, Synthroid and Levoxyl, that because of all the fillers that they basically are, they peak differently in the bloodstream once they're absorbed, they're metabolized differently into T3 or reverse T3. I think all of those excipients really do matter, and that's
Hmm.
why A lot of times as thyroidologists, we tell patients, make sure you don't change manufacturers or make sure your CVS or your Walgreens doesn't get a cheaper version and then put you on that because it can really impact how you feel because of how you metabolize the medication.
Mhm. So if you want to start to keep track of that, that would be a great publication also.
I think it would be. I
Yeah.
absolutely think it would be. And I think this is what we're seeing in real life. So
Hmm.
getting all of those numbers correct for patients and getting all of those numbers, T4, T3, reverse T3, TSH, all of them optimized is important in wellness. And that is what we're trying to do when we try to mimic the thyroid with these imperfect medications. All of them are imperfect medications. They all have to be dosed extremely correctly. This is a medication with a very narrow therapeutic index, so you have to have somebody who knows how to dose them correctly. And that is the key to patients feeling better. So I have the role of reverse T3 here as five different things. So it's a competitive inhibitor of T3 binding to receptors, which is why it's so important for it not to be high. I also think that there's an optimal range for reverse T3. So probably if you were just looking at patients outside the reference range, I think there's probably more of a optimal range for RT3 as well. So more patients probably are affected that way. I think it's important to look.
What would you say is the optimal range?
I use 12 to 16 on like the
Okay.
standard LabCorp Quest
Hmm.
test. I
Okay.
mean, that's really like the 50th percentile median.
Hmm.
And I think it's important to look at the ratio of reverse T3 to T3. When I was at Duke and I was doing some basic science on MAFLD, NAFLD, and T3 and reverse T3, we looked at serum levels of that and
Hmm.
it correlated with fibrosis. So like looking at how the
No.
body
Okay.
actually like metabolizes thyroid hormone can also have big effects for these end stage metabolic consequences that we're seeing and a lot of the inflammatory and chronic disease that we see in patients.
And
Number two,
if you see a low reverse T3, what do you think of that? Do you do anything for that?
it just depends. It depends on if the patient's on T4. I usually think that they are either malabsorbing the medicine or they're not spacing it correctly.
Hmm.
Or they're underdosed, or they're using more of their T4 to convert to T3. We see that
Hmm.
sometimes in like ultra marathoners or in people with a lot of muscle mass who work out a lot because the primary substrate in muscle is T4 for intracellular T3. So, it just depends on the person, but you need that information in order to properly dose patients and
Hmm.
understand what's going on.
Hmm.
Um, Reverse T3 isn't an inert metabolite, but it's really important in dosing. So what you just described in that paper is very important, and that should be something that every endocrinologist reads, honestly.
Thank you. Thank you.
I wish that they would. I wish that they would.
It's got a lot of people, a lot of views on in the journal, so it will. We're going to publicize it more. You please on your website encourage people to tell their doctors about it.
Absolutely. So yeah, so I mean the main role of our T3 is diversion away from T3, active T3 production. So we see that it goes high in illness and stress. That's what sick euthyroid syndrome is. And the thought process is that the body does that on purpose in order to decrease, metabolic stress and reduce oxidative stress, so that the body can heal and so that the body isn't seeing too much free T3 in an injured state. And then also, I think it's a marker of metabolic dysregulation. I think there have been papers that show that reverse T3 is higher in patients with higher fat mass. It's higher in chronic disease. So I think it's a really good biomarker for there's something wrong with this person because
Hmm.
metabolizing their thyroid hormone properly. And then it's the question of whether it's the chicken or the egg. Does this cause continued metabolic consequences? I think it does. Or is it just a marker of an underlying metabolic disorder that just gets worse with time? So you can keep going there. All right, here are my rules on how to optimize patient therapy. This is what I do. So first, I consider the thyroid replacement product. There are multiple different products on the market. There's T4 only, there's T4 plus Cytomel or T3. There's natural desiccated thyroid for the time being. We will talk about that here shortly. I use slow release products. I use compounded products. I will use whatever product I have available for patients because there are patients that metabolize thyroid medicine differently. And that's in part due to genetics, that's in part due to other hormones that affect the binding proteins that's because of GI issues. All of these medicines are absorbed in the small intestine. They are working on some novel products that are injectables. But for now, everyone's different. I also consider issues with interference, dissolution, small bowel absorption. There are solutions of T4. I have some people chew medicine in order to break it down and help with the dissolution process, especially in the stomach if they're on PPIs. I also ask to consider individual patients and multiple variables that impact alter peripheral metabolism and conversion. This is why it's so hard to do a thyroid study and show significance, especially in TSH. And that's because there are so many variables that go into how somebody takes the medicine and uses it and what happens with TSH. And do they actually absorb it every day in their small intestine? And is there anything that interferes? It's really, really hard to do a study in thyroid. Also, make sure that your therapy mimics the real thyroid as closely as you can, meaning that all metabolites are optimized, and that the medicine is lasting for you for the full 24 hours. And then try your best to optimize all the thyroid hormones with your limited imperfect artificial medications that are available. And hopefully down the road, we will have additional better options for people. But until that time, using what we have as optimally as we can.
Right? When would you say you use desiccated thyroid versus, say, T4, T3?
I find that patients who make a lot of reverse T3 do much better on natural desiccated products, honestly. So patients
Mhm.
who have severe osteoarthritis, patients who are morbidly obese, patients who have a chronic state of inflammation or who are on inhaled steroids, patients who are on beta blockers, which we know inhibit T4 to T3 conversion.
Hmm.
All of those people do better on NDT.
Right. There's a surge in people going on beta blockers for either POTS or tachycardia. So I think you're completely right. It really is detrimental to your therapy. Very common medicines. Okay, so I completely agree with my colleague, Dr. Henderson. There's many options for thyroid hormone replacement, T4 alone, levothyroxine, synthroid, levoxyl tyrosine, which is a liquid gel, which capsule, which I like, Unithroid. There's gel capsules, tyrosine, generic tyrosine, Thyquidity, T3, acidomyl or liothyronine. You can give it alone or in combination with T4. There's desiccated thyroid. I was very excited about Ephesa, but it looks like it's no longer available. Armor and natural thyroid, WP thyroid, IRFA. The one that's we use now is called um, Nature Throid. I don't know why I put that up. Yeah, there's Nature Throid. With WP thyroid is not really available either. So Nature Throid is one of the best ones. These are also called natural desiccated thyroid or desiccated thyroid extract, DTE. You just call them desiccated thyroid. You can have combination of T4 plus desiccated thyroid. And it's really important to individualize treatment. There's not just one blood pressure medicine. There should not just be one thyroid medicine. Combination medicines are often needed. However, there's multiple studies that have shown poor quality of life among patients on levothyroxine replacement alone. So many patients, especially in my accounting job, they're on T4, Synthroid, they're doing fine. Maybe they have other things to worry about, such as, being deported by immigration or something like that. But many patients do fine on it. And I would say about 85% of the patients that in the country do fine on levothyroxine treatment, they have a normal TSH and they do okay. But about 15% of the patients with hypothyroidism on levothyroxine treatment have a normal TSH but hypothyroid symptoms. This was in a consensus guideline for treatment of hypothyroidism with Dr. Junkless. These 15% of the patients that are not doing well in spite of having a normal TSH are the ones that see Dr. Henderson and me. And since the thyroid secretes T4 and T3, many patients need both. And I think conventional endocrinologists just overlook this basically. They give everybody T4 and sort of hope that their T4 gets converted to T3. And some people yes, and some people no. Um, so most of the time, the people that come to see me, I think need something else besides T4. I have some patients on T4, but not too many of them. Desiccated thyroid or DTE has T4 and T3 in a fairly good ratio. And the synthetic products don't have those. So they have other things, also T1 and T2, that may be helpful. And it's, Dr. Henderson said, imperfect world with imperfect synthetic drugs. At least the desiccated thyroid is the same thing as the pig thyroid makes. It's not the same thing as a person thyroid makes, but it's still, pretty similar. There used to be concerns, and when I was in my fellowship, I regurgitated those concerns about the lots being different. But the company NutriThroid and Armor are big companies. They have bats. They make their product very carefully. They test each lot. So I think that's sort of a carryover from the past. The people that sort of a bias against desiccated thyroid still use that when it's really not true. There's 7 peer-reviewed articles, some good and some not so good articles that show desiccated thyroid was preferred over levothyroxine, and some articles show it's preferred over T4 plus T3. My colleague, Dr. Hong at Bethesda Medical, has published 2 very good studies on that. There really hasn't been any studies showing that T4 is better than desiccated thyroid. The side effects in most of these studies were hypothyroidism, were minimal. And bottom line is basically patients feel better on desiccated thyroid. There was a Medscape article that's right there that people can look at showing that. So this is my colleague Stan Hong and Mohammed Shekhar published this article in Journal of Clinical Endocrinology and Metabolism 2021. One of their tables was treatment preference, and I pulled it up here. And they ranked them the best treatment, the second best, and the third best. And you can see desiccated thyroid extract. More people ranked that number one, 34%, 34 of them, 45%, like desiccated thyroid, 32% or 24 patients like the best T4, T3, and only 23% like T4 alone. And then the second ranking was sort of in the middle. And the third ranking, the one they liked the least, was desiccated thyroid was the lowest amount that. So more people like desiccated thyroid. However, this wasn't significant. They used fairly small numbers. This didn't be significant, but it really shows that in a blinded study, the patients did not know what they were taking. They still like desiccated thyroid over T4, certainly, and even over T4 plus T3. So I put most of my patients on desiccated thyroid. I put some on T4, T3 combination. The T3 has a short half-life, and so desiccated thyroid and T3 really need to be given twice a day if you're going to sort of mimic what the body makes. Otherwise, the patients are hypothyroid in the evening, and by the next morning, they're really hypothyroid. Their labs really show that they would have a low free T4 the next morning. And I think this is underappreciated and crucial. I had to call the patient today, though. She couldn't take it twice a day. She's taking it once a day. She's feeling great, but I think she's an exception over the rule. I don't use much compounded T3, but I like Dr. Henderson's use of it. It can be compounded to once a day treatment and can be a good person, good saver in somebody that just can't remember to take their medicine twice a day. Most of my patients can sort of remember to do that. Dr. Henderson, do you want to comment a little bit about compounded T3?
Yeah, I'm also gonna comment that desiccated thyroid and T3 need to be given twice a day. That is 100% true. Anybody who does thyroid medicine, more than just a hobby, knows that
Mhm.
that's the
Yeah.
so there is a question in the chat about, the fact that desiccated thyroid might have a higher T3 ratio, a T4 to T3 ratio as compared to in humans. And that's true if you give it all once daily in the morning time, that you will get TSH suppression. Typically, you'll get a T3 that comes out of the reference range.
Hmm.
But the goal here is to use an imperfect medication as perfectly as possible to mimic human thyroid. And the way to do that is by dosing smaller amounts multiple times daily. Patients
Hmm.
with that, it lasts for the full 24 hours. It's not a 24-hour drug. And they metabolize it better. So patients feel better on this. As far as my compounded T3, yes, we use this a lot. It's easier to take a once daily dose for patients. It also mimics normal thyroid physiology, which is where the T3 doesn't just spit out all at once like Cytomel does or
Hmm.
liothyronine. It actually is slowly released throughout the day. Not perfect in everybody, but definitely feels better. And if you put somebody on a 24-hour monitor and you were able to measure that, you would see that you have much more stable T3 levels, and that is
Hmm.
what the goal here with any of the products that we're using.
Right. So in general, I tell my patients to take the thyroid medicine first thing in the morning on an empty stomach. I think this 4 hours away from food is a little exaggerated. I think most of it gets absorbed somewhat quickly, so 45 minutes or an hour might be okay. For the twice a day treatment, which I recommend, second dose mid-afternoon, 2 or 3 in the afternoon. It's sort of farther away from lunch and dinner. You don't have to worry about with food. And doesn't keep them awake at night. I usually try to avoid late at night treatment, but some people take it late at night and they do okay. But in general, I recommend second dose mid-afternoon. Avoid taking with iron. It's a big culprit. Calcium, vitamins with iron and calcium, proton pump inhibitors, which are super common, carotene, bisphosphonates, orlistat, cholestyramine. I find there's only a minor effect of soy. I usually don't make that big a deal about soy. I try to get the free T3 and free T4 to mid to upper range. I make small changes and repeat labs frequently. I usually don't worry about the low TSH, except in an elderly, sicker patient. Then I'm a little bit more worried. A young, healthy person, I'm not really that worried. The main two things you're worried about with the low TSH are high bone turnover, osteoporosis, or osteopenia, or cardiac arrhythmias. A young person is not going to get cardiac arrhythmia. They might get palpitations occasionally, but it's very rare for them to get cardiac arrhythmia. I like doing a test called a urine peptide, which looks at bone turnover. If it's high, then I might back down a little on their dose, but if it's normal, I'm usually okay with keeping the TSH suppressed. Okay, Dr. Henderson, the bridge.
This is my lovely little slide. So everybody is wrong. And part of our social media campaign is that, there's conventional medicine's idea about how to do this, and then there's functional or integrative medicine's idea on how to do this. And really, like, there's only one right way to do thyroid medicine, and it's by trying your best to basically get everything into the optimal range. All of the metabolic breakdown products, looking at the full thyroid panel, using the tools that we have in our toolbox to the best of our ability to keep people as optimally dosed as possible for the full 24 hours. And and not overdosing patients. I mean, it feels terrible to be on a high dose of thyroid medication, just as bad as it feels to be hypothyroid or underdosed. So this is a Goldilocks drug. It has to be dosed perfectly. It also changes with time. So when patients are pregnant, the dose changes. When they go through menopause, the dose changes. As their weight comes down with all of these GLP-1s, the dose changes. If they have inflammation, if they're sick, there's so many variables. And so really it is a work in progress with these imperfect medications. I wish we had something like a thyroid pump that you would wear and it was a closed loop system and it just figured it out. That's what the thyroid does. But we have so many people that had total thyroidectomies for these sub-centimeter papillary thyroid cancers or like just go
Horrible.
whatever. It's just and surgeons just said, oh, whatever, you could just take Synthroid. No, you can't. And now there's a war on natural desiccated thyroid. FDA is trying to take this away. This is a good segue into that. These poor patients need therapeutic options. I have patients who have tried everything that's commercially available. They have anaphylaxis with T4 or levothyroxine. What are they going to do if they don't have this option? It's not okay. We went thyroidectomy happy and then being on our side of this, trying to help patients regain their normal life and live a normal life without symptoms. It's hard. It's hard to do. And so there is not a one size fits all approach here. T4 only is not going to work for everybody. T4 plus T3 is not going to work for everybody. That's why we have to get inventive with how we dose things, and I have to compound things. And, it's just, we do not have great tools, but we do the best that we can to mimic a really important endocrine organ for patients. So, the moral of my story is that everybody is wrong, but there is one right way to do this. That's why I'm on this podcast or on the Zoom call to try to talk to other endocrinologists and talk to other patient advocates and patients about spreading the word that, we really need to start doing a better job as providers on this. And you as a patient, if you're a patient, talking to your provider about the paper that Dr. Friedman published. That's an excellent resource for them. It speaks the language to these endocrinologists to kind of look at that. And then, they could be like, whoa, this is high. What do I do?
Hmm.
So, even commenting to your own providers would be extremely helpful in getting people to listen.
Or come see Dr. Henderson or me.
Yeah, that's fine too. We
Right.
can't see everybody, but I mean, we do need to educate, and help people understand that this is not being done correctly. The American Thyroid Association has yet to even make a statement about NTDE being taken off the market. It's been like 40 days. It's really a sad state of affairs in thyroid medicine, and there are some people like us who are board certified endocrinologists, and we're sounding the alarm that something is very wrong with how this is being done. But there are a lot of brainwashed endocrinologists that will not open up their minds and listen. So, so that brings us to this. This is the FDA ban on natural desiccated thyroid. So August 6th, probably some of you already know this, there was a letter that was sent out by the FDA to the manufacturers of natural desiccated thyroid. The two main manufacturers right now are AbbVie, who makes Armour Thyroid, and Acela Pharmaceuticals that makes NP Thyroid. Nature Throid is no longer available. WP is no longer available. Adisa is no longer available. Levothyroxine is available, but barely anybody's prescribed that. This also includes all of your bovine thyroid extracts that are made by your, supplement companies. So, all of those extracts, GTA Forte, or all of that is subject to this ban, in addition to compounded thyroid USP. So even if they take it away, you can't get that either. And the reason that they said, which really is concerning, it doesn't really make any sense. There's three reasons. The first is batch to batch variability. That happens with levothyroxine too. Like there have been in the last month or two, 160,000 bottles of levothyroxine removed because of decreased potency and variability. So this is a common thing, not just specific for thyroid. So that doesn't make very much sense. Number two was the potential for viral contamination. This medicine's been available for over 130 years. And even in the letter by the FDA, they said, since 1960s, there's been 500 patient complaints or adverse events. There have been, estimated reports of like 30,000 from levothyroxine. So it just really doesn't make sense that this theoretical issue with 130 years of real world data would come up now, that we would have to get rid of it. And these companies do test their products for contaminants. They know they are biological products. So that's why they're FDA regulated, and they have to do this. They have to look for batch consistency. They have to check for viral infections and other issues. And then also that there's super physiologic levels of thyroid hormone T3 provided by ADT products. Yeah, well, that's only if you are being dosed by a provider that doesn't know how to dose them correctly. And just like any T4 product, if you are overdosed on the medicine, you're going to have super physiologic T4 and T3 levels. That is a provider problem, not the NDT problem. So, that it was the letter, and that we have basically 12 months before they start taking action against the manufacturers and taking these products off the market. This really cannot happen in real life because we have 1.5 million Americans that are on these products, probably way more than that. And they've tried everything synthetic. I have patients who've tried everything and they can't tolerate anything but this medicine. They've had their thyroid surgically removed, or they've had autoimmune thyroiditis for many years. And by the way, Dr. Freeman, when you were talking about the TPO antibodies and if they're negative and the TSH is high, we see TPO antibodies and thyroglobulin antibodies negative all the time in patients who've had longstanding Hashimoto's disease. And that's because either they're in remission, just like any other autoimmune disease, and that can happen. We see changes by ultrasound. I use thyroid
Right.
ultrasound.
So it's very important.
And then, patients who've had it for 25 plus years, sometimes they have atrophic thyroiditis. There's nothing left for the immune system to attack. So in those,
Mhm.
you know, they will not have antibodies, but they do have Hashimoto's.
Right.
Um, so anyways, also, there's bias, a lot of bias in the endocrine community, in conventional medicine, community about natural desiccated thyroid, probably because a lot of this is used in the integrative and functional medicine community, by sometimes practitioners that don't know how to dose it, but there are practitioners that do. And then, that there's a need for oversight and regulation by the FDA. Yes, there is. That's why most of these companies who produce these products are in phase 2 or phase 3 clinical trials. They are complying with this. They knew that they had to have this through FDA approval by 2029. And now all of a sudden this letter comes out and they have 12 months. There's no way you can get through a phase 3 clinical trial in 12 months and get it all approved. It doesn't make any sense. It's just a waste of resources and and really mean, honestly, because I had patients in tears when this came out. Like, what are we going to do? This is my whole life. It's not okay. It's not okay to do this at the expense of patients and their lives for a profit. And that's honestly what it seems to be, because it doesn't make any sense otherwise. This is the one of the change.org campaigns that we have going. There's multiple of them, and we're asking people to please write to your representatives, please write to the FDA, to explain your position, that this should be an available form of medication for patients, and it's really a matter of life or death for some people.
Okay, well, I agree with you completely. Well, the FDA is not imposing the immediate ban on natural desiccated thyroid, but has initiated action that could lead to its removal from the market in the year. In August 2025, the agency notified manufacturers that NDT and other animal-derived thyroid extracts previously grandfathered into use without modern approval are considered unapproved biological products that require a biologics license application, or BLA. So what happens next? There's a 12-month period. They didn't ban it immediately. They give people the option, if they want, to transition to an FDA-approved synthetic thyroid medicine. As Dr. Henderson said, this is not an option for most patients. Manufacturers must follow this BLA process. As of September 2025, no manufacturers completed this process, making it unlikely before August 2026. And it's unclear if the companies, the sell, and I'll show you my response from my Cellular sales rep on the next page, or AbbVie from Armor, will successfully complete this BLA process in time to meet the new regulatory requirements. Patient advocacy is important. Patient groups and advocates are lobbying against these restrictions, expressing concerns that patients will feel better on NDT. They lose access to their peripheral treatment options. So I think this is very important. FDA Commissioner Marty McCarvey, the day after this came out, posted the agency would ensure access for patients during the approval process. He says FDA is committed to pursuing the first ever approval of desiccated thyroid, pending results of ongoing clinical trials. In the meantime, we will ensure access for all Americans. So I think when this response came out, I thought that please stop making notes on the screen here. I think when Dr. McCarvey's social media post came out, I felt that this is probably not going to materialize. Um, my Acella's rep sent me a text. She likes to text me. She said, and I quote, the MP thyroid continues to be the number one desiccated thyroid extract in the US as a replacement or supplement therapy patient with hypothyroidism. We know that MP is a consistent quality alternative for patients not responding well to traditional levothyroxine only products. We will be working with the FDA to re-examine their position to ensure that DTEs, including MP thyroid, remain available to the 1.5 US patients rely on them. We encourage you to give us time to work with the FDA to change the position or extend the timeline to match our effort to get our DTE product approved. If you want to express dissatisfaction with the FDA, you can contact the FDA. These numbers and emails showing this petition, and the two petitions are listed. So my take is the FDA has been trying to ban DTE since 2022. With Dr. McCarvey's comments and strong pushbacks, my guess is it won't. The MP thyroid clinical trial is almost complete and should pave way for FDA approval. from what the sales rep says, that it's going to finish very soon, and it does look positive that NP thyroid is both safe and effective. So, Dr. Henderson, thank you so much. There's her website. She has two websites. She's the states that she practices in. This is her social media. She's the president of the Thyroid Foundation. Dr. Henderson, do you want to add?
Can I just say one thing? So I
Yes.
Macri's comment and his tweet was good, but I would caution everybody to not get, like not just give this up and just say, oh, it's not going to happen, because until there's a formal letter retracting
Hmm.
that, that is,
Right.
possible that in 12 months they will be taking this away. And some of the things that came out after his tweet, by some of these FDA representatives did reference the letter still that we have 12 months. So I
Hmm.
still think it's really important to not just let this go by the wayside and pretend that it's gonna not happen. I'm I'm pretending for my own sanity that it's not going to happen, but I think we need to talk to our representatives. We need to, sign the petition. We need to do everything that we can in our power to have our voice heard in Washington and ensure this doesn't actually happen.
I agree. Exactly. So this will be posted on my website and on YouTube, and I think on Dr. Henderson's website. Our Facebook channel is this. We have podcasts. This is going to be recorded as a podcast. You can go to these podcast channels. You can email us if you need a copy. Please visit Dr. Henderson's website and view her social media. If you live in the state she's licensed, please feel free to see her and continue seeing me. Let's go to the chat. Tiffy, do you want to read some of the chat questions?
Yes. Yes. So I'll start with Facebook and then we'll go to Zoom. Lynn asked how many hours should be between the first and second dose when they were talking about T3 or T4, I think, or their medications.
I usually say 8 to 12 hours.
Because like one should be in the morning, one should be in the afternoon, but how many hours between it?
I was just answering, yeah,
Right.
8 to 12 hours between.
Okay, perfect. Thank you so much.
And
Patricia
I'm okay
asked,
with sort of 6 or 8, first thing in the morning and mid-afternoon, somewhere around there.
Mhm. Patricia asks, how does thyroid affect bone density?
Too much can give you osteoporosis, but most people don't take too much. You have to be on a pretty high dose to really get that.
Okay,
I,
Colleen.
I agree.
Mhm. Awesome. Colleen asks, how does low ferritin affect thyroid hormone levels?
So you need iron for T4 to T3 conversion. It's important in deiodinase function. And so when you have a low ferritin, you usually don't convert your T4 as well to T3, which is one of the big contributors. It's actually the number one micronutrient deficiency in the world is iron
Hmm.
deficiency.
Right.
But something to think about if you're a menstruating female or even if you're postmenopausal, a lot of our GI tracts don't pick it up very well from food. So it basically inhibits T4 to T3 absorption or
And also figured it affects the binding the receptor post receptor signaling. So your levels may look okay, you just don't signal properly. So I try to aim for a ferritin above 70. Do you try to do about that, or
80 is usually what I say.
AIDS? Great. I completely agree with that.
Awesome. Dr. Amy Hoffman said, I noticed a big difference between Athesa and NP thyroid. I feel better on NP thyroid. I believe it has 3 inert ingredients rather than 5 that are more simplistic in nature. That's just a comment. Um,
Dr. Henderson, do you have a favorite desiccated thyroid?
I don't have a favorite anything, honestly. I'll use them all.
Okay.
mhm.
But I do like products that are cleaner. So that does speak to me as far as less dyes, something that's gluten-free, dairy-free, that doesn't have opandry white. I don't love that. I mean, I think that the less the better, as long as it's enough inert ingredients to not make it super instant release, because that also feels terrible to people.
Mhm.
Mhm.
My sort of back of the envelope experience is that MP thyroid's a little better formulated than Armor. I think Armor has a little bit more T3 in it than the MP does. So I think you get a little bit evener levels with MP. So I usually like MP the best. have places on Arm and they're doing well also. And I think it's unfortunate that these is not on the market as it was a good option, but there's other ones still.
Mm-hmm. All right, we have a question. Desiccated thyroid has a good T4/T3 ratio. Isn't the ratio much higher than in humans? I'm not really sure what that means.
We talked about that. I think we
Right.
just talked about that the fact that it has to just be dosed properly and then
Mhm.
it can mimic normal human levels.
Right.
Okay, great. I tried epithyroid and it didn't work for me at all. I have been on Athesa and found it to be fabulous. Second, only WT thyroid neither is available anymore.
Unfortunately. So that's why we are working to hopefully preserve the ones that are available and on the market. And don't forget the one above the comment above that, because that's my study. I didn't talk
Mhm.
about that's my clinical study, I think.
Which is what?
Awesome.
The small intestinal bacterial overgrowth
Mm,
and
okay.
we looked at converting people from tablet to solution in SIBO. We found that 70% of patients with hypothyroidism had SIBO, small intestinal bacterial overgrowth. And we test for that a lot in our patients.
Hmm.
Um, but switching to the liquid form of the medication basically helped completely resolve IBS symptoms in 1 in 5 patients, 20% of patients. And it improved both IBS symptoms and thyroid symptoms despite normal, despite TSH levels that are equivalent, before tablet or with tablet and with solution. So there is something to be said about consistent delivery of T4 or T3 medicine to the body every single day. And there are thyroid receptors in the GI tract as well.
Hmm.
So thyroid being delivered to that GI tract does help with motility. It improved, the BSC score, how the stool looked. It improved frequency and motility and stool behavior, which all go
Wow.
into IBS. So yeah, very important to think about intestinal bacterial overgrowth in these patients.
How do you assess SIBO?
It's a breath test. That's the gold
Mm-hmm.
standard. So
Hmm.
basically, a patient drinks an artificial sugar solution, and then you can measure methane and hydrogen as in the breath in 30 minutes, an hour, 90 minutes, and 120
Okay.
minutes. And they're treated differently, but very, very common in this population.
Well,
Right.
Dee asked and also stated a research study found that number one risk for small intestine bacterial overgrowth was taking levothyroxine. The risk was higher than untreated hypothyroidism. Thyroid meds weren't included. Other thyroid meds were included. Any theories as to why the risk between SIBO and levothyroxine?
So yeah, so it's the motility issue. So anything that impairs motility. And we know hypothyroidism is very much associated with delayed motility. Also, levothyroxine in and of itself, we think, has an impact in growth of those bacteria in the small intestine. Because little do some people know, levothyroxine, some of its excipients are sugar. Like they use confectioner sugar in one of them as a actual inactive ingredient, and sugar feeds these bacteria. So it's probably not the best, especially the products that have sugar as a inactive ingredient in SIBO and in preventing that.
Thank you, Brittany. Um, and then Dr. Amy Hoffman asked, so as consumers and patients, what can we do to help stop the ban?
I think Dr. Friedman had that in one of his slides here about where you can go and who you can contact. And then if you follow me on social media, I'm at Dr. Henderson MD on Instagram mostly and Facebook, Dr. Henderson MD. I have in the letter like where you can write to your representatives as well.
Awesome, thank you. And then, so anyone with GLP-1 type medicines may be at risk for SIBO.
That's correct.
Okay, hard stop.
But if you optimize the thyroid medicine, you can overcome that.
Okay.
Right, Dr. Anderson?
I mean, it definitely helps, but GLP-1s in general just slow bowel motility. So those
Hmm.
patients could be at a higher risk for overgrowth of bacteria. Now, one good thing about GLP-1s is it lowers insulin and blood sugar, which
Mhm.
help with that. So it kind of evens it out a little bit. But yes,
Right.
you are at a
Reduces
high.
inflammation.
Yeah.
Um, Another question is, what happens if you overdose on thyroid medication? Like if you're taking too much of it?
You get palpitations, sweating, hyperfeeling, insomnia, and can eventually lead to osteoporosis, increased bone resorption, cardiac conditions. We would both of us recommend being on the right dose, not too much or too little. Goldilocks effect.
Right. And then if you take thyroid medication in the evening and you also take iron in the evening, is that an okay?
No, I mean, iron definitely impairs the absorption of thyroid medicine.
Mhm.
Unless you're on something like tyrosine or tyrosine solution, like explicitly that you're still supposed to space it, but it definitely impacts absorption from the small intestine. So you want to space that. I tell my patients at least 2 hours,
Mhm.
not opposite end of the day.
Great. Okay, we have a couple more questions and then we'll probably call it a day. VS, is there an optimal RT3 or does it just need to be in range?
Reverse T3, I like right in the middle of the reference range. So it depends on your reference range, but 12 to 16 is typically what I use.
Right.
I'm happy as long as it's not high.
Perfect. Okay, one more question. Amy, when will doctors and emergency rooms stop checking just TSH to determine if thyroid is off?
That's going to be a long time because we still have to convince endocrinologists to not just check TSH. So we have a lot of work to do. It's going to be a long road to try to correct the way that we do things, honestly.
Mhm. Great. Pat said slash asked, I have been successfully taking a unithyroid and unithyroid for many years. If you live in many states other than California, will they ship directly to patients for reasonable prices, or is that not the case?
For Unithroid,
Unithroid.
yeah. So Unithroid is can be get at regular pharmacies. Should not be an issue. Um,
Okay, Gina asked, Dr.
I like
Henderson.
I like Unithroid a lot. Also, I think it's a good product.
Great. Gina asked, Dr. Henderson, what hospital system are you affiliated with in Charleston?
I just answered her that I have my own practice. It's called Charleston
Oh,
Thyroid
okay.
Center, and
Okay,
I'm
perfect.
also online. I'm licensed in 9 different states,
Mhm.
mostly in the Southeast, but Arizona, Minnesota, Ohio as well.
All right, awesome. All right, I think that might be all our questions for today.
Okay. Thanks everybody for joining. We'll post this in a couple days. And thank you again, Dr. Henderson. It was a great discussion. I
Thank
really
you. It was
enjoyed
a
it.
wonderful talk.
Oh, really good. Okay, bye bye.
Thank you. Bye bye.